Welcome to a review of pertinent drug information for SARS-CoV-2 presented by the Society of Infectious Diseases Pharmacists. My name is Tom Dilworth, and I'm a Pharmacy Coordinator of Infectious Diseases at Advocate Aurora Health, based at Aurora St. Luke's Medical Center in Milwaukee, Wisconsin. Today I will present an update of ACE inhibitors, ARBs, and NSAIDs in patients with COVID-19. These data are current as of May 6, 2020, and are an update to a previously available presentation from March of this year. The objective of the talk today is to review available evidence and organizational positions supporting use or discontinuation of angiotensin-converting enzyme inhibitors, or ACE, angiotensin receptor blockers, or ARB, and non-steroidal anti-inflammatory drugs, or NSAIDs, in patients with COVID-19. First, I'd like to review COVID-19 infection. It is caused by severe acute respiratory syndrome coronavirus 2, or SARS-CoV-2. SARS-CoV-2 uses the angiotensin-converting enzyme 2 receptor as a human cell entry point for infection. And it's notable that ACE2 is expressed near the surface of human epithelial cells throughout the body, most notably in the lung, which is the entry point of the virus, given that it is droplet-oriented. I'd also like to review the Reninangiotensinaldosterone system, or RAS, because I think it's informative when you start to think about the pros and cons of ACEs and ARBs in patients with COVID-19. So first off, you've got a schematic on the right-hand side that shows angiotensin-converting enzyme converts angiotensin 1 to angiotensin 2. Now, angiotensin 2 is a vasoactive peptide. It causes systemic vasoconstriction and aldosterone release. And if you remember, aldosterone causes sodium and water retention, which leads to increased blood pressure. So in patients who have high blood pressure or diabetes, blocking this cascade can be really helpful. The downstream effects of angiotensin 2 are blocked by both ACE inhibitors and ARBs. Now, these medications will also increase ACE2 expression. This is important because ACE2 will actually provide a check against the renin-angiotensin system by catalyzing angiotensin 1 and angiotensin 2, the degradation products of which promote vasodilation. So, yes, ACE2 is upregulated, but that is also a positive effect for these patients. When you talk about RAS and COVID-19, I've already told you that SARS-CoV-2 binds to ACE2 as a cell entry point for infection. Well, SARS-CoV-1, the previous coronavirus, when it was binding to ACE2, led to ACE2 downregulation and increased angiotensin 2. Both angiotensin-converting enzyme and angiotensin 2 will promote lung disease progression and murine pneumonia models. Moreover, ACE inhibitors and ARBs upregulated ACE2 expression in animal models, and you can see that on the lower right-hand side here, where ACE2 mRNA expression was increased by approximately 5-fold and 3-fold in Lewis rats exposed to lisinopril and losartan, respectively. So what about ACE and ARB use and COVID-19? Well, there is the potential to increase the risk of SARS-CoV-2 attachment and subsequent COVID-19 infection among patients being treated with ACEs and ARBs. However, this is not substantiated by any human data, and it is an urgent research priority. ACEs and ARBs may reduce lung injury in some viral pneumonias. As I've already described, the ACEs and ARBs can prevent ACE and angiotensin 2 lung disease progression. But I do think it's also important to note the underlying medical conditions of patients infected with COVID-19. On the upper right-hand side, you'll see data that were presented at CROI earlier this year. These are data out of China. And you see the underlying medical conditions of patients with COVID-19 and then their disease severity stratified as mild, severe, or critical. And the one thing you'll note is those with hypertension, diabetes, cardiovascular disease, and lung disease had much higher rates of COVID-19 infection, and then also much higher rates of critical and severe COVID-19 infection. So patients with these comorbidities are disproportionately affected by COVID-19 infection. Additionally, on the lower right-hand side, you'll see patients with cardiovascular disease, or with or without cardiovascular disease, and with or without elevated troponin. And the rates of mortality were highest in those with cardiovascular disease and with an elevated troponin. So these patients are already at a fairly high risk for an adverse outcome when it comes to COVID-19 infection. So to summarize the potential pros and cons of ACEs and ARBs for COVID-19 infection, on the pro side, they may minimize COVID-related cardiovascular and lung damage, but probably more importantly from my standpoint is they can maintain cardiorenal protection for patients who need them. These drugs are prescribed for a reason. They do reduce mortality in patients with diabetes and heart failure, so they're very important to maintaining these patients' quality of life and disease-free survival. On the con side, they may increase susceptibility to COVID-19 infection. So that's animal model data and in vitro data and speculation. The professional societies came out very early on and said, continue taking ACEs and ARBs, whether it's European societies or Canadian societies, societies out of the UK, notable American societies like the American College of Physicians, American Society of Pediatric Nephrology, the American Heart Association, American College of Cardiology. Now, this is probably one of the biggest updates to my presentation here today, and these are observational data looking at ACE and ARB exposure in hospitalized adults with COVID-19 infection and hypertension. So the first was over 1,000 patients in China. This is published in Circulation Research in mid-April. 17% were given an ACE or an ARB, and they looked at mortality. They did a very robust statistical analysis, including multivariable logistic regression and propensity score matching. Their unadjusted mortality results showed that those given an ACE or an ARB had a 3.4% mortality compared to a 9.8% mortality with no ACE or ARB, so a threefold reduction in unadjusted mortality. When they did a multivariable analysis, they found that ACEs and ARBs were protective with an adjusted odds ratio of mortality of 0.42. And when they looked at a propensity score analysis based on the propensity to receive an ACE or an ARB and matching to like patients, that odds ratio was still 0.37 with a confidence interval that did not cross 1. So my takeaway from this study is there's no harm in patients taking an ACE or an ARB, and there may be potential benefit. Yes, they did a robust statistical analysis, but this is an observational study. It is not a randomized controlled trial. The next study was also out of China. This was 362 patients, about a third of whom got an ACE or an ARB. The outcome of interest was disease severity or mortality. It was a composite endpoint. I don't have the numbers up here for you. There was no statistical adjustment, and there was no difference in severity or mortality. This was published in JAMA Cardiology, and the reference is there if you'd like to pull it. But my takeaway from this is there's no harm in ACE or ARB exposure in patients with COVID-19. You'll see that's starting to be a consistent theme. Continuing on with the observational studies, this was a study on the left is a study out of the United Kingdom. 205 patients, 18% of whom got an ACE inhibitor within 7 days of COVID symptom onset or while they were in the hospital. Their outcome was a composite outcome as well of mortality or need for ICU care. They did perform a multivariable regression analysis looking at predictors of their primary outcome. Unadjusted data, the mortality or need for ICU care was 14% in the ACE exposed group versus 29% in those who did not receive an ACE, so about a 50% reduction. And then when they ran a multivariable analysis, they found an adjusted odds ratio of 0.29 with a confidence interval that did not cross 1. So my takeaway from this study is also that there's no harm in taking an ACE inhibitor when you have a COVID-19 positive patient, and there may be some benefit. The next study was a study published recently in Clinical Infectious Disease out of Italy, 311 patients, again, about a third who received an ACE or an ARB. Their outcome was just mortality. These patients were much older than patients in the other studies that I presented, and they were extremely comorbid, lots of comorbidities in this cohort. They did a multivariable regression analysis looking at predictors of mortality, and the two predictors of mortality that were maintained in their model were an elevated SOFA score and an elevated or older age. Exposure to an ACE or an ARB had no bearing on mortality. So my takeaway from this is, again, no harm with an ACE or an ARB when it comes to mortality in this cohort. The final study I want to share with you was recently published in the New England Journal. This was a study in New York City, a single health system, and they looked at two different outcomes. The likelihood of having a COVID positive test, and then having, if you had a COVID positive test, severe disease defined as ICU care, ventilatory support, or mortality. So to start off, their catchment was over 12,500 patients. 46.8% ended up being COVID positive, and 17% of those had severe disease. Now, this was a very intense analysis. They looked at patients with hypertension and without hypertension, and then they looked at patients who got hypertension meds, including calcium channel blockers, beta blockers, ACE inhibitors, ARBs, and thiazide diuretics. And then they did propensity score matching based on each antihypertensive drug class for both those with hypertension and without. And no matter how they cut up their data, they found no difference in exposure to any hypertension medication and the outcomes of interest, be it a COVID positive test or severe disease. The takeaway from the authors, and my takeaway as well, is that there is no harm in ACE or ARB exposure for patients in terms of conferring a higher risk of COVID-19 infection or more severe disease when a patient does have COVID-19 infection. So my summary here on the right is ACEs and ARBs are not harmful. We've got 5 observational studies, one of which is a preprint. There is also a potential benefit, but these are retrospective observational data. They're not controlled, despite their statistical analysis. I'd be cautious to say there's benefit, but there are ongoing trials to study the impact of ARBs as COVID therapy. As I mentioned, COVID-19 is more common in patients with diabetes and cardiovascular disease. In the previous SARS-CoV-1 epidemic, mortality was 12-fold higher in these populations. We know COVID-19 induces myocardial injury, and we see worse outcomes among patients with cardiovascular disease and those with elevated troponin. We also know that SARS-CoV-2 binding causes ACE2 downregulation, which has deleterious effects that could be mitigated by ACE or ARB exposure. So putting that all together, there are 2 ongoing losartan trials for outpatients, and one for outpatients, one for inpatients with COVID-19. So these are patients who don't necessarily need losartan therapy, but they're being given losartan as an investigational agent to see if it improves outcomes for COVID-19 infection. Now I want to shift gears and I want to talk about NSAIDs. So previously, this slide was not included. I thought it was important to just take a step back and look at the data as it relates to NSAIDs in non-COVID-19 respiratory tract infections. So there was a nice review last year that looked at NSAID exposure and the rates of complications following respiratory tract infection. This was a review of observational studies, and they did find there was a link between NSAID exposure and complications following respiratory tract infection. One of those studies in particular was a Danish cohort of almost 60,000 patients, and they looked at pleural pulmonary complications with NSAID use. And they found that these complications occurred in 3.8% of patients exposed to NSAID compared to 2.3% of those without NSAID exposure. And then in their multivariable analysis, the adjusted odds ratio of pleural pulmonary complications was 1.81, with the confidence interval that did not cross 1 for those exposed to NSAIDs. There was also a trial of primary care patients with respiratory tract infections in the United Kingdom. These were patients greater than 3 years of age. Almost 900 patients were randomized to one of 3 treatments: paracetamol or acetaminophen, ibuprofen, or both paracetamol and ibuprofen in combination. Now, their primary outcome was the mean symptom severity on days 2 through 4. They found no difference between these groups, paracetamol, ibuprofen, or both, in terms of mean severity of symptoms on days 2 through 4, but they looked at a number of secondary endpoints, one of which was reconsultations with new/unresolved symptoms or complications, which occurred in 12% of paracetamol-exposed patients versus 20% of ibuprofen-exposed patients, indicating that there was a higher risk of reconsultations with new or unresolved symptoms or complications in those exposed to ibuprofen, with a risk ratio of 1.67 that was statistically significant. So those are non-COVID-19 respiratory tract infections. So some have argued that NSAIDs do worsen outcomes in respiratory tract infections. Now, as it relates to COVID-19, as I discussed previously, ACE2, similar to ACEs and ARBs, may be upregulated by ibuprofen, but that's really not the case. This was mentioned in one letter to the editor in Lancet Respiratory Medicine, and no citation was provided. As I called the literature, I found one piece of evidence that would support ACE2 in, upregulation, and that was in a murine model where the authors actually concluded that ibuprofen could ameliorate the cardiac fibrosis in diabetic rats by reduction of ACE axis and enhancement of the ACE2 axis. So it is true that ACE2 is upregulated in this study, but the net effect was positive in terms of amelioration of cardiac fibrosis in diabetic rats. There's also data to suggest NSAIDs blunt IgM and IgG synthesis. That has been used to sort of further the argument that NSAIDs should not be used for COVID-19. But really, despite the letter that was in Lancet Respiratory Med, the French health minister came out on Twitter on March 23rd and said, or suggested avoiding NSAIDs in COVID-19, and this gained substantial traction on social media and in the mainstream media, and patients were very worried. This definitely created a bit of a firestorm, and it was a lot of misinformation that unfortunately us as healthcare providers, had to do our best to kind of get out ahead and dispel that misinformation. There's no published data to support ibuprofen avoidance in COVID-19, and FDA, to their credit, on March 19th said there's no scientific evidence connecting the use of NSAIDs like ibuprofen with worsening COVID-19 symptoms. There's other organizations that have weighed in on this as well, including the World Health Organization and the European Medicines Agency, or EMA. And I liked how they framed it. They said when starting treatment for fever or pain in COVID-19, patients and healthcare professionals should consider all available treatment options, including paracetamol and NSAIDs. Each medicine has its own benefits and risks. So arguing for a patient-specific decision rather than a blanket statement like avoid NSAIDs. I'd also draw your attention to the fact that notable U.S. physicians have also not recommended ibuprofen avoidance, including David Aronoff, Carlos Del Rio, and Anthony Fauci, who is currently advising President Trump as it relates to the COVID-19 pandemic. Now, since the last time I presented, we've got a number of guidelines that have been promulgated, and I think it's important to review these guidelines as it relates to NSAIDs and COVID-19. So the first will be the NIH guidelines, the National Institutes of Health, who say persons with COVID-19 taking NSAIDs for a comorbid condition should continue therapy. So I think that's a pretty firm endorsement. There are going to be patients who need chronic NSAID therapy, and they should continue taking them. They also said there's no difference in the strategy of antipyretic use, whether it's acetaminophen or NSAIDs, as in patients with or without COVID-19. So saying either one would be appropriate. The National Institute for Health and Care Excellence in the United Kingdom said the following: advise patients to take paracetamol or ibuprofen if they have fever and other symptoms that antipyretics would help treat. The Infectious Disease Society of America did not put forth a recommendation as it relates to NSAIDs, but they did discuss NSAIDs. They said there's no causal evidence of adverse outcomes with NSAIDs in the management of COVID-19 that have been published, and randomized control trials are needed to better understand the safety of NSAIDs in the management of patients with COVID-19. Now, the Society of Critical Care Medicine, SCCM, said back in their guidelines on March 27th, the use of NSAIDs to treat fever in patients with COVID-19 continues to be debated. Until more evidence is available, we suggest using acetaminophen or paracetamol to treat fever. So they took a slightly different tact, but overall here, I'm not seeing a lot of evidence that from these guidelines that we need to avoid NSAIDs, particularly in patients who need them chronically. The WHO also put forth another statement on April 19th. They did their best to review literature. Unfortunately, there isn't much, and their conclusion was there's no evidence of severe adverse events, acute healthcare utilization, long-term survival, or quality of life in patients with COVID-19 as a result of the use of NSAIDs. So that is what the WHO had to say about that. I think as, coming from a pharmacist, it's always important to weigh patient-specific factors and, competing risks as it relates to selecting NSAIDs versus acetaminophen. So there's a number of groups of patients you'd like to avoid NSAIDs, particularly those patients who are late in pregnancy, patients with liver disease, patients on systemic anticoagulation, patients with kidney disease, patients taking ACE or ARB therapy, patients with hypertension, patients with stomach ulcers, and then there is recommendations to avoid aspirin, which is an NSAID, in patients with asthma. Conversely, it's prudent to avoid high doses of acetaminophen in those with liver disease, so staying less than 2 grams per day. And then patients who chronically abuse alcohol, as alcohol and acetaminophen are both metabolized through the liver. Now, one thing I think is important is to talk about liver disease. I think there's a misunderstanding as it relates to liver disease, where people feel you should not give Tylenol to people who have, say, end-stage liver disease or chronic liver disease. And the reality is you should probably preferentially give them Tylenol, just at a dose of 2 grams per day or less. And the reason for that is that NSAIDs will exacerbate coagulopathy and hepatorenal complications in those with end-stage liver disease. Now, the other caveat to this is that these products are available over the counter, and they're in an innumerable number. They're in innumerable combination cough and cold products. And often patients don't even know they're taking acetaminophen or an NSAID. And these are used by millions of patients every year. And it's important to remember that analgesics are a common cause of poison center use here in the United States, both intentional and unintentional. So it's important that we advise our patients correctly when they're picking over-the-counter medicines. Finally, I want to touch on the therapeutic potential for COVID-19. And this will be very brief, but indomethacin demonstrated cytotoxic activity versus SARS-CoV-1. And there's a preprint up on bioRxiv right now that used protein-protein interaction mapping and identified indomethacin as a potential SARS-CoV treatment. So that's a very nascent step towards developing some sort of treatment, but I do think it's worth mentioning. Probably more exciting is naproxen. So there are data to suggest naproxen can bind the nucleoprotein of influenza A, which is similar to the nucleoprotein of SARS-CoV-2, and thus naproxen may have some activity versus SARS-CoV-2. Naproxen is now being, or will soon be studied against the standard of care in critically ill COVID patients. There's a trial that's registered on clinicaltrials.gov that I've included the number there. This is to be a randomized open-label study in France with an estimated N of 584 patients. The rationale put forth by the investigators is the putative antiviral activity of naproxen combined with its known anti-inflammatory activity. The exposures will be naproxen 250 milligrams twice daily, combined with lansoprazole 30 milligrams daily for gastrointestinal protection versus the standard of care. And the primary outcome is 30-day mortality. Again, these are going to be critically ill patients in the intensive care unit. And they have numerous secondary endpoints looking at changes in SOFA score and time to weaning off mechanical ventilation, etc. So with that, I'd like to conclude with 3 things. The first of which is there's no reason to avoid ACEs or ARBs in COVID-19 positive patients. Patients should continue taking them as prescribed, and stopping them may do more harm than good. The second is there's no reason to avoid NSAIDs in COVID-19 patients. They should continue taking them as prescribed. And anti-inflammatory selection should be based on patient-level factors, not whether or not a patient has COVID-19. And finally, more research is needed on concomitant non-antimicrobial pharmacotherapy in COVID-19 patients. With that, I thank you for your time and attention, and my contact information is listed there, and on behalf of the Society of Infectious Disease Pharmacists, thank you for listening.